Hi, are you able to hear me? Hari Babu, can you hear me?
Yes, ma'am.
So I'll go ahead and start then. I'm Dr. Pranitha, consultant neonatologist and pediatrician in KIMS Hospital, Kondapur. So let us start with the case. A 28-weeker male baby with birth weight 900 grams was born by LSCS in view of maternal abruptio placenta. Only a single dose of steroid could be given just before the delivery. Baby did not cry immediately after birth and required PPV support followed by intubation. Baby had to be ventilated in view of inadequate respiratory support and later developed respiratory distress and was given surfactant. By the end of day 1, baby was shifted to CPAP and day 2 was uneventful. On day 3, baby started to have mild tachypnea, tachycardia with bonding pulses. So at this point of time, our differential is PDA and sepsis. So let us discuss about patent ductus arteriosus. What is PDA? PDA is a shunt which is present between aorta and pulmonary artery, 5 to 10 mm distal to the origin of left subclavian artery. So PDA is absolutely essential in utero for a baby, while after birth it has to close. So PDA can be of various morphological sizes. It can be tubular, it can be short, conical, or window shaped. It can be saccular, elongated, fetal type, and sometimes it can have a complex anatomy. So the PDA closure rates in a term baby, usually PDA closes functionally by the end of 24 hours and by the end of 48 to 72 hours. In 100% of cases, it closes off structurally also. While in babies born more than 30 weeks of gestation, 10% of ducts are still patent by the end of day 4 and only 2% are patent by the end of day 7. While coming to a 28-weeker baby, almost half of the ducts are patent by day 4 and 40% of ducts are open by day 7. In a 24 to 25-weeker baby, only 4% of ducts close by day 4 and 13% close by day 7. So if we follow up rates by day 60 to day 80, in babies born between 25 weeks to 28 weeks, most of the ducts close by day 60. While in babies born between 23 to 24 weeks of gestation, by day 60, 33% of ducts are still patent and 14% of ducts are still patent by day 80. So what are the risk factors for the patency of duct? The most important risk factor is gestational age. The lower is the gestational age, the higher is the duct patency. Lack of antenatal steroid coverage before delivery also plays a significant role in maintaining duct patency. Indomethacin tocolysis and magnesium sulfate administration to mother before delivery is also a risk factor. And post-birth history of asphyxia, respiratory distress syndrome, and surfactant administration all lead to PDA. PDA is also seen higher if there is excessive fluid administration, especially in the first week of life. Infections like sepsis and some infections like rubella also lead to PDA. Thrombocytopenia is associated with higher risk of PDA, and some syndromes like trisomy 13, 18, and Robinson-TB syndrome are all associated with PDA. Sometimes the duct can close and it can again reopen later, especially in case of presence of sepsis, NEC, fluid overload, especially in a Elgan baby. So let us discuss very briefly about the factors promoting postnatal duct closure and duct patency. So post-birth, usually there is decrease in pulmonary vascular resistance, followed by increased systemic vascular resistance. So the fluid in the lungs is going to get absorbed and PVR slowly decreases. The oxygen tension is going to increase. The increase in oxygen tension is the most important factor which leads to the constriction of duct. And with the clamping of the umbilical cord and increase in systemic vascular resistance, there is usually blood flow into the lungs from the aorta to the pulmonary artery. There is also decrease in vasodilator like nitric oxide and prostaglandins. Prostaglandins are destroyed in the lung and prostaglandin receptors are downgraded. Along with this, some factors which increase the constriction of duct like endothelin, angiotensin 3, bradykinin, and some catecholamines like acetylcholine, norepinephrine all help in closure of duct. There are also certain structural factors which help in closure of duct in a term baby, like the smooth musculature is more mature and responds well to oxygen and contracts well. The vascular intimal cushions are more prominent. Vasovasorum is more active, and platelets are also usually more active in a term baby. These are all deficient in a premature baby. So if you can see the picture here, the second picture is the duct in a preterm baby where the lumen is wider, the intimal cushions are narrower, and the smooth muscle cells are not much developed. Whereas in a term baby, the media is thicker and the intimal cushions are very well developed. So coming to the clinical features of PDA, the clinical features of PDA depend mainly on the ductal shunt. So how much is the duct size, the ratio of SVR to PVR, the ability of immature myocardium to adapt to the increased circulation. And similarly, there are symptoms of pulmonary overcirculation with systemic hypoperfusion. So let us discuss each one in detail. So because of the duct PDA, blood flows from the aorta to the pulmonary artery, especially if it's a left to right shunt, leading to pulmonary overcirculation. This leads to worsening of respiratory distress after initial improvement. There is usually increased respiratory distress, tachypnea, reduced lung compliance, oxygenation failure, interstitial and hemorrhagic pulmonary edema leading to pulmonary hemorrhage, and in the final stages leads to BPD. So this is the chest X-ray picture showing increased pulmonary vascular markings along with cardiomegaly. So coming to the symptoms of left heart volume overload, because of the increased pulmonary overcirculation, the left heart is going to receive more blood from the lungs. And hence there is usually clinical symptoms like continuous or systolic murmur is usually apparent more late, but initially there can be hyperdynamic precordial pulsations, wide pulse pressure, easily palpable peripheral pulses, especially dorsalis pedis and pulses in the palm. There is usually compensated tachycardia to increase stroke volume. And initially there is hyperdynamic systolic function, later there is diastolic dysfunction. And in the late stages, there is systemic hypotension along with pulmonary venous hypertension. So normally QP should be equal to QS. The amount of blood supply going to the lung should be equal to the blood supply coming from the heart to the systemic vessels. But in the presence of a hemodynamically significant duct, QP is going to increase and QS is going to reduce. Because of decrease in QS, there is usually hypotension leading to metabolic and lactic acidosis. There is also decreased blood supply to the kidneys from the renal arteries, which leads to decreased urine output, azotemia, and in late stages AKI. There is decreased blood supply to the intestines, leading to, in the early stages, it leads to increased abdominal distension, aspirates, and in later stages to NEC. There is also fluctuating blood flow to the brain, which leads to IVH, PVL. And in some cases, there can be death also because of multi-organ dysfunction. So while all these signs are seen in babies who are already on a support like a CPAP or ventilator, the signs might be more subtle, like there can be only some increased respiratory distress or higher FiO2 requirement, and baby might be having apnea while on ventilator. Coming to the complications of PDA, there can be some early complications and there can be late complications. The early complications because of pulmonary overcirculation are pulmonary edema leading to pulmonary hemorrhage. And in the late stages, it can lead to BPD. And because of systemic hypoperfusion, there can be end organ dysfunction leading to MEC, IVH, and PVL. So the odds of death increases by 3.4 times because of the PDA, and the odds of BPD increases by 3.7 times, and the odds of IVH increases by 4.2 times. So having known the clinical features of duct, now it is important for us to know if the duct is hemodynamically significant or not. So there are various classifications. One of them is by Sosanka, who has classified that a duct is hemodynamically significant in the presence of clinical signs of PDA or pulmonary hemorrhage or cardiomegaly. And if there are signs of pulmonary edema in the form of respiratory failure with or without arterial hypotension requiring vasopressor support. Then there is a more famous McNamara staging where it's an elaborate staging based on clinical signs and echocardiographic signs. So clinically, PDA is divided into 4 stages: C1, C2, C3, C4. C1 is an asymptomatic duct, C2 is a mild duct, C3 is a moderate duct, and C4 is severe duct. So in mild PDA, usually the OI is less than 6. There is little oxygenation difficulties, occasional apneas, desaturations, and baby might be on a CPAP support or a mechanical ventilator support with MAP of less than 8. There can be slight feeding intolerance with more than 20% of gastric aspirates, and on X-ray we can see increased pulmonary vascular changes. While in a moderate period, there is more oxygenation difficulty with OAS 7 to 14. There are frequent desaturations every hourly apneas, and there is increased ventilation requirement with a MAP of 9 to 12. Now, abdominal distension is more significant here. You may have to stop feeds. There is oliguria with increase in plasma creatinine. There is hypotension requiring a single inotrope. And on chest X-ray, we see usually cardiomegaly with pulmonary edema. If you take a ABG, there is usually metabolic acidosis with pH ranging between 7.1 to 7.25 and a base of -7 to -12. In a severe duct, usually OI is more than 15 with MAP requirement of more than 12. Baby might be requiring HFO support, and baby is usually having NEC like clinical picture abdominally, and baby might be in acute renal failure. There is need of more than one inotropic agent, and metabolic acidosis here is more severe with pH of less than 7.1 and base of more than -12. So this is how you differentiate the duct clinically, and echocardiograph wise we'll go one by one. So echocardiograph wise, we again classify the duct into 3 types for the hemodynamic significance. So the first one is based on the ductus arteriosus characteristics, the size of the duct, the shunt direction on color flow Doppler, and the flow pattern across the ductus arteriosus. Then pulmonary overcirculation is assessed by the volume overload in the left side of the heart, LA by AO ratio, increased LPA diastolic velocity, mitral E by A ratio, and left ventricular function. And systemic hypotension is assessed by postductal aortic blood flow pattern and blood flow pattern in celiac trunk, SMA, anterior cerebral artery, middle cerebral artery, or SVC flows. So first we need to find out if the duct is present or not. So initially we need to place the probe in the high parasternal region or the ductal view. Usually it is placed in the second intercostal space, and slightly if you tilt the probe towards the right side, you will be able to visualize the aortic arch. There is ascending aorta, aortic arch with descending aorta. Then if you tilt the probe little more left, usually aorta will disappear and pulmonary artery will appear. So pulmonary artery will usually divide into RPA, LPA, and the duct. Sometimes this may not be visible so clearly as in this picture. So when you are not able to differentiate the duct clearly in a 2D picture, color Doppler flow is going to be helpful. Now here you can see the red flow showing the presence of duct. So having confirmed the presence of duct, next we need to confirm the flow pattern. So this is the first picture where there is pulmonary artery. It is divided into RPA, that is right pulmonary artery, left pulmonary artery, and the PDA. So this is called 3-leg stool appearance or 3-leg trouser appearance. So now we need to measure the size of the duct. The size of the duct is measured usually at the pulmonary end of the duct. So see that you do not measure the anterior wall of the pulmonary artery. You need to measure at the duct at the pulmonary end. So sometimes the size is usually dynamic in a duct. Usually whatever we see is a two-dimensional structure, but duct is actually a three-dimensional structures. And there can be many complex shapes and diameters which may also lead to errors. So here we have measured the size of the duct at the pulmonary end, which is 1.6 mm. After measuring the size of the duct, we will classify it into a small duct if it is less than 1.5 mm, moderate if it is 1.5 to 3 mm, and large if it is more than 3 mm. So never measure the size of the duct in a 2D structure, always measure in a color Doppler. Sorry, never measure in color Doppler as it will exaggerate the size. Next, we need to find out about the direction of the shunt, whether the shunt is from right to left, that is pulmonary artery to the aorta, or whether it is bidirectional, or if it is left-right, that is from the aorta to the pulmonary artery. So just immediately after birth, there is increased in pulmonary vascular resistance and PVR. So this is depicted below the line. The flow from right to left is depicted below the line. This is the blue flow. So initially there is only right to left flow. Later, slowly pulmonary vascular resistance will slowly decrease and there is decreased pulmonary blood pressure, and simultaneously there is increase in systemic vascular resistance. So now here in the second picture, we can see both the flow is below the line, which is the right to left shunt, and there is also flow above the line, which is the left to right shunt. So at a certain point of time, the pressures, both pulmonary blood pressure and the systemic blood pressure are equal. That is when both the shunts are equal in size. Then as the systemic blood pressure slowly increases, now there is more flow only on the upside of the line. This is a growing pattern. And as the size of the duct increases further, this is pulsatile flow. So there is high systolic velocity and low diastolic velocity. So again, let us see this. So in the first picture, there is both left to right flow as well as right to left flow, but here more it is orange flow is more evident. So whatever blood flow is coming towards the transducer is usually orange in color, and whatever is going away from the transducer is usually blue in color. So here there is both bidirectional shunt, but the left to right shunt is more. In the second picture, we see mostly blue jet, that is right to left shunt, which is visible below the line. So these are again pictures of the same right to left shunt. Here we can see clearly the MPA differentiating into RPA, LPA, and duct. And when we place the Doppler along the duct, there is right to left shunt predominantly. So now as the pulmonary vascular resistance starts decreasing and the systemic blood flow starts increasing, left to right shunt is slowly increasing. The first picture is a bidirectional shunt. Even here you will be able to appreciate both orange as well as blood flow. And slowly as the systemic blood flow is increasing, the left to right shunt is slowly increasing. So here the blood flow is predominantly orange in color. So sometimes right to left shunt might be little difficult to assess, especially because the blood flow in both pulmonary artery as well as the aorta in blue. And it is easier to appreciate an orange blood flow rather than a blue jet between the pulmonary artery and the aorta. So it is always better to place a Doppler to know if there is any right to left shunt. So after seeing the direction of the shunt, now we need to measure the flow pattern. We need to see how is the flow pattern and the velocity of the ductus flow. Usually, if the size of the duct is very small, the flow will be more. I mean, the velocity of flow will be more and the actual flow will be decreased. That is, flow is inversely proportional to the velocity. So in a closing pattern duct, the flow velocity is more than 2 meters per second. So in a PDA with restrictive flow but continuous flow, also the velocity is more than 2 meters per second. In a moderate PDA with unrestricted pulsatile flow, the flow velocity is slightly lesser, 1.5 to 2 meters per second. And in a large HSPDA, the velocities might be lesser than 1 meters per second. So these are all again the flow patterns. The picture in the right below one is the right to left shunt. Sorry, purely right to left shunt. This picture is a bidirectional shunt, but the right to left flow is only more predominant. So C and D are restrictive patterns in the presence of HSPDA. So here we measure the peak systolic velocity and peak diastolic velocity. So usually in the pulsatile pattern, peak systolic velocity is high and the peak diastolic velocity is little low. And when you measure the ratio, it is little high. But as the duct becomes more and more HSPDA, the peak systolic velocity slightly decreases and the peak diastolic velocity increases. And the ratio of peak systolic velocity and the peak diastolic velocity decreases. So we can also measure the velocity in left pulmonary artery. So usually the probe is placed in the plaques view and slightly tilted from the right shoulder towards the left shoulder. So that is when the aorta disappears and the pulmonary artery appears. So we see the right ventricle, it opens into the pulmonary artery and we see the pulmonary artery branches. So if you place a Doppler over there, usually the diastolic velocity will be there. So just like how the blood is shunting from the aorta to the pulmonary artery, there is increased diastolic flow even in the pulmonary artery because of the ductal shunt. So these velocities we can measure, and if it is a mild duct, usually the velocity is less than 0.2 meters per second. In a moderate duct, it is 0.2 to 0.5 meters per second, and a severe duct, it is more than 0.5 meters per second. Okay, that is all about the duct characteristics. Now coming to pulmonary hyperperfusion. This is measured indirectly by seeing the left heart indices like dilated left heart, mitral regurgitation, mitral E by A ratio, isovolumic relaxation time, LA by AO ratio, and left ventricular output. So in the first picture, this is from the apical view. The probe is placed in the apex area, and we are able to see the 4 chambers. So on eyeballing, we can easily clearly demarcate that the left side of heart is much more dilated when compared to the right side of the heart. And when we place a Doppler here, there is a blue jet seeing. So normally here the probe is below, the transducer is below. So when the blood flows from left atrium to the left ventricle, it has to be an orange flow. But we are able to see a blue flow, which means it is a mitral regurgitation. So this is Kraft's view showing pulmonary veins. Here the pulmonary veins are all dilated. And in the last picture, this is plaques view. In plaques view, we are placing the transducer in the high parasternal region facing the right shoulder. So the up one is the right ventricle, this is the aorta, and this is the left atrium. So we measure the LA by AO ratio here. So coming to LA by AO ratio. So if the ratio is less than 1.4, the duct is mild. If the ratio is between 1.4 to 1.6, it is a moderate duct. And if the ratio is more than 1.6, it is a severe duct. So like we just discussed, we are going to place the transducer in the plaques view and we are going to press M mode. So this one is the right ventricle, the upper one. The middle one is the round one is the aorta. This is the left ventricle and this is the LA. So even by eyeballing, we are able to make out that the LA is little larger. Usually aorta's diameter is not going to change. So if there is LA, there is dilatation of left atrium, the ratio is going to increase. So after placing the in M mode, we are going to place at the level of the aortic valve and we are going to take the ratios. So aortic diameter is the upper one, which is measured at the end diastole, and the left atrial diameter is the below one, which is measured at the end systole. And LA by AO ratio is calculated. So coming to other signs of the left heart dilatation, the first picture is showing pulmonary artery blood flow. So this is again viewed in plaques view. You are going to tilt the transducer slightly to the left side. The aorta will disappear and the pulmonary artery will appear. You're going to place a Doppler there. So normally you only see this kind of flow if there is no PDA. But in the presence of PDA, there is some blood flow even seen in the diastole. So coming to mitral E by A ratio, normally blood flow in the left ventricle is filled first passively, that is the E wave is because of just passive filling, and A wave is because of atrial contraction. So in preterm babies, because of diastolic dysfunction, the E wave is lesser and the A wave is larger. But in the presence of HSPDA, because of the PDA, there is increased atrial contraction and there is pseudo-normalization of E by A ratio. That is, E is increasing more than A. So in mild PDAs, it is ratio is 1. In moderate PDA, it is more than 1. And in severe PDA, it is more than 1.5. So this is measured in the apical view. We place the probe in the apical view and the doctor is placed across the aortic valves and we measure the E and A ratios. So based on the left heart dilatation, we are going to classify the PDA into mild, moderate, severe based on the severity of dilatation. And isovolumic relaxation time is also measured in the apical view only, the view which we have just seen for the E by A ratio. This is where we measure the isovolumic relaxation time. So in the presence of the PDA, usually the mitral valve is going to open faster because of the increased blood flow. And the isovolumic relaxation time is going to decrease. So in the mild PDA, it is more than 40 milliseconds. In moderate PDA, it is 30 to 40 milliseconds. And in severe PDA, it is less than 30 seconds. And because of the increased blood flow to the left heart, the left ventricular output is also going to increase. So this is less than 200 in a mild PDA, 200 to 300 in moderate PDA, and more than 300 in a severe PDA. So this is all about pulmonary hyperperfusion. Next, coming to systemic hypotension. So because of ductal steal, the blood flow to the systemic arteries are all going to reduce. So this we are going to measure in descending aorta, abdominal aorta, SMA, superior mesenteric artery, celiac artery, anterior cerebral or middle cerebral arteries. So in a mild PDA, usually the flow is normal. In moderate PDA, there is absent flow in the diastole. And in severe PDA, there is retrograde flow in the diastole. So this is in the subcostal view. This is abdominal aorta, and the first branch is celiac trunk, the second branch is the superior mesenteric. So if it is a normal, in a normal baby, there is going to be slight flow even in the diastole. But in the presence of PDA, initially there is absent flow in the diastole, followed by reversal of flow. So the reversal of flow is seen above the line. Similarly, we can also measure the Doppler flows across the middle cerebral artery or the anterior cerebral artery. So there should be flow both in systole as well as diastole, which is normal. In the presence of mild PDA, there is absent flow in the diastole, followed by reversal of flow, which is seen below the line in severe PDA. This is again the same picture. The first picture is showing flows in the abdominal aorta. In a normal baby, there is antegrade flow with some flow even in the diastole. Later, the flow in the diastole is disappearing. Next, there is flow in the retrograde flow in above the line. So forward flow is seen as in the diastole here, and we are also able to see the retrograde flow above the line. So we have seen how, so forward in the diastole here, and we are also able to see the PDA into HSPDA based on the echo findings. Now coming to the treatment of PDA. So the treatment of PDA is controversial whether to treat or not is an ongoing debate since many decades. But there is definitely a subgroup of infants who will likely benefit from interventions. So benefits of treating PDA is reduced need for ligation, but there is no changes in immediate outcomes like death, BPD, ROP, or MAC. And there is no change in long-term neurodevelopmental outcomes. There are some contraindications for closing PDA. So duct-dependent pulmonary circulation or duct-dependent systemic circulation is an absolute contraindication for closing PDA. And severe PPHN with right to left shunt or bidirectional shunt is also a contraindication for closing PDA because here PDA is life-saving. It is going to reduce the pulmonary pressures. So whenever you are attempting to close PDA, it is always essential to get the 2D echo by cardiologist to rule out these two conditions. So coming to the different types of treatments of PDA. One is the targeted early prophylaxis where we are going to treat all the babies within 12 hours of life, especially babies less than 26 week or babies or less than 750 gram babies. So this is Cochrane review on prophylactic intravenous indomethacin for preventing mortality and morbidity in preterm neonates. This also includes the famous TIP trials by Barbara Schmidt. So total of 19 trials are included with 2,800 infants. The advantages of prophylactic PDA closure is there is decrease in HSPDA, decrease in surgical ligation, and severe IVH. But the limitations are 30 to 50% of infants who may not require the treatment are also exposed to the treatment. There is no change in long-term outcomes like BPD, NEC, and neurodevelopmental outcomes. So the next form of PDA closure is the early targeted treatment, where we are going to see by echo, we are going to diagnose a PDA within 72 hours. A PDA which is large is going to be treated. So this is also recommended for babies less than 28 weeks of age and less than 72 hours of life, especially if the size of the duct is more than 1.6 mm and the LA by AO ratio is more than 1.5 mm. Next is the symptomatic approach. Here we are going to wait for 72 hours. Only once the signs and symptoms of PDA develop, then we are going to treat. So signs of PDA will develop much later when compared to the signs of in the echo by lag of 1 to 4 days with a mean duration of 2 days. So in this, it can be either early symptomatic treatment, which is done after 72 hours and less than 1 week, and late symptomatic treatment, which is after 1 week. So HSPDA on echo, along with clinical symptoms of pulmonary overload and systemic perfusion, then we are going to treat the PDA. So while the treatment of PDA is controversial, one thing we can do is conservative approach, where we target the fluids of the baby, ventilation of the baby, and the circulation of the baby. So coming to fluid and electrolytes, we need to give adequate fluid, but always reduce overload and dehydration. It's always better to dehydrate the baby a little in the first week of life, which decreases the chances of HSPDA. So aim for at least a weight loss of 7 to 10% in the first week of life. And also aim sodium little higher value. So high fluids are going to increase the chances of PDA. Coming to ventilation, if the baby is on CPAP, give adequate PEEP. If the baby is on ventilation, try to give volume targeted ventilation with adequate positive pressure. Allow permissive hypercapnia and avoid hyperoxia. Do not hyperventilate. And coming to circulation, we always need to maintain a proper preload, because inotropes and vasopressors are going to act only when there is adequate preload. And when needed, you can use inotropes or vasopressors, and maintain a PCV of more than 35 to 40%. So coming to the different drugs. So the two drugs which were used initially were indomethacin and ibuprofen. Both of them are non-selective COX inhibitors. So indomethacin is given at a dose of 0.2 mg per kg, 12 hourly for 3 doses. The dose slightly differs based on the gestational age and the duration of life. And the dose of ibuprofen is 10 mg per kg, followed by 5 mg per kg every 2 hours. So the rates of closure are almost similar for indomethacin as well as ibuprofen, but indomethacin is associated with higher renal failure and higher risk of NEC. So clinical trials have proven that there is no difference in the closure of the duct reopening after the first course, or the need of retreatment with either agent, the need for surgical ligation, or the long-term outcomes like ROP, IVH, survival rates, or developmental outcomes with both indomethacin and ibuprofen. Indomethacin is, however, associated with increased risk of NEC. So coming to ibuprofen, there are two forms you can give, either orally or IV. So oral brufen has lesser chances of closing the duct when compared to ibuprofen, and it is also associated with higher risk of NEC. So again, there are two types of dosage strategies for brufen. In the first one is the high dose oral brufen, where we are giving a loading of 20 mg per kg, followed by 2 doses of 10 mg per kg at 12-hourly interval. And the standard dose is what we discussed earlier, 10 mg per kg, followed by 2 doses of 5 mg per kg. The closure rate is slightly higher with high dose of oral brufen, but the renal side effects, NEC and platelet dysfunction, there is no difference. And coming to the paracetamol, which we are more commonly using these days. So the mechanism of action of paracetamol is not very clear, but it is thought to be because of inhibition of peroxidase mediated conversion of prostaglandin G2 to H2. The dose is 15 mg per kg 4 times a day for 5 days. The closure rates are 70 to 100%, almost equal to indomethacin and brufen. And the complications of indomethacin is not seen with paracetamol, like the peripheral vasoconstrictive effects. There is no risk of NEC or IVH, or there is no risk of kidney renal dysfunction. Paracetamol is, however, contraindicated in hepatic failure. So when we compare oral paracetamol versus brufen, there is no difference in closure rates, mortality rates, cardiorespiratory changes, reopening rates, IVH, NEC, or surgical closure rates. But brufen is associated with higher risk of AKA and GI bleeds. So coming to surgical closure of PDA, this is attempted whenever there is contraindications to medical therapy like NEC or AKI, or we have already used two courses of medical therapy, but the duct is still HSPDA and baby might be requiring ventilator support. So surgical closure can be done either by a device method or an open surgery method. Device method can be done in a baby weighing more than 700 grams and more than 3 days of age. So surgical ligation, when we compare it with medical treatment, is associated with increased odds of neurodevelopmental impairment, BPD rates, and severe ROP, but there is decreased odds of death. But this might also be because the babies who are undergoing PDA ligation might be more sicker babies, more immature babies who might be already on prolonged ventilatory requirements. So complications of PDA ligation are post-ligation cardiac syndrome, acute kidney injury, vocal cord and diaphragmatic paralysis, chylothorax and pneumothorax, sepsis, IVH, hypertension, prolonged ventilation, and BPD. Coming to post-ligation cardiac syndrome, this is because of abrupt increase in left ventricular afterload and decrease in left ventricular preload because of the closure of duct. So the risk factors for PLCS is baby less than 4 weeks of age, weighing less than a kg, less than 26 weeks, and the need for inotropes prior to surgery. There is basically rapid decline in LV output. In 50% of preterm babies where the myocardium is already immature, there is gradual decline in LV systolic and diastolic functions. So the signs of the low cardiac output are apparent 6 to 12 hours post-operatively. But by echo, we can diagnose this by first hour of life. Might be slight tricuspid valve injury leading to tricuspid regurgitation. So to treat or not to treat is always a dilemma. So there were two studies done where babies were randomized. The preterm babies less than 29 weeks out of 1200 babies, 300 of babies were less than 26 weeks. In group 1, there was medical treatment was given or surgical ligation was done. And in group 2, there was no treatment given. So in babies born between 26 to 29 weeks, there was no difference in death or BPD rates. But in group B, the death or BPD rates increased by 31% in babies born less than 26 weeks. So there was no change in outcomes in group 1 babies who received that medical treatment of PDA in babies less than 26 weeks also. So certainly in babies who are extremely low gestational weight, especially babies less than 28 weeks or 26 weeks, it is always better to close PDA, aggressively close PDA. So coming to the summary, PDA is the most common cardiac condition affecting the newborns. The clinical signs of PDA appear much later, 1 to 4 days compared to the echocardiographic findings. Treatment of PDA is not associated with improved long-term outcomes. And the short-term benefits of treatment like decreased IVH, decreased symptomatic PDA, surgical ligation, PBL have not translated into improvement in long-term neurodevelopmental outcomes. So thank you. We'll give you a short demonstration of the duct bedside.
Hello. Can I ask? Hello, ma'am. Hello. Hello.
Hello,
Hello.
yes, sir.
Yes, myself, Dr. Melin, as a assistant professor and NX in charge at IGMC Nagpur.
Sir.
Ma'am, it's a very wonderful your talk. Can you share me this PPT, ma'am? Actually, I recently started USG doing a NIS. I just want to share your
Yes, sir, I'll share it, sure.
I send my mail idea on chat also.
Okay, sir, sure.
Or ma'am, can you also you have weekly such a tutorials academics. So can you share me also on my WhatsApp number so that I will join every weekly?
Yeah, we'll do that.
Okay, I will send my number also. Okay, okay, ma'am. Okay. Thank you.
Thanks.
Okay. Thank you.
So we'll show the basic views of echo followed by a live demonstration of PDA. Screen baby. So sorry for the slight delay. So first, before doing the demonstration of PDA, always follow complete aseptic precautions. Baby needs to be comfortable, not crying. So I'll start with paracetamol long axis view because that is going to give the more information and compared to other views. So in paracetamol long axis view, the transducer, the head of the probe is usually placed facing towards the right shoulder in the high paracetamol region. So sometimes you may have to change the position of the transducer a little to get the correct appropriate location. So here you are able to see the three chambers. The below one is the left atrium. So the circular one is the aorta. The aorta is connecting into the left ventricle. This is the left ventricle. And the upper one is the right ventricle. So what all will you be able to locate in the plaques view is one, you are going to be able to see the aorta if there is any valvular disturbances, aortic stenosis. You are going to measure the chamber length. If there is any dilatation in any of the chambers, you can see that. You can also see the contractility of the chambers of the. You can measure the left LA by AO ratio and LV by AO ratio. And usually if you tilt, so normally aorta and pulmonary artery should not be visible in the same view. In TJ, we'll see both aorta as well as the pulmonary artery in the same view. If you tilt the probe with the head of the transducer slightly towards the left, the aorta is going to disappear and we're going to see the pulmonary artery. So this pulmonary artery, we can see the velocity of pulmonary artery here. And when we are doubtful of the presence of the duct, this view is best to know if there is a duct or not. So we are going to place the Doppler flow in the pulmonary artery. And like we have discussed in the presentation before, usually there is increased flow in the diastole also in the pulmonary artery, which means there is a presence of duct. Okay. So we can also measure the ejection fraction in this view. And if there is any ventricular defect, we usually be able to see a flow between the ventricles in this. And interventricular septum thickness can also be measured, especially in a baby who's an IDM baby. If there's any pulmonary valve stenosis, can be measured with tilting the duct little towards superior. So next, coming to the ductal view. Ductal view is seen by placing the transducer in the high parasternal region, usually maybe in the second parasternal region. So aorta is visible slightly to the right, and we will be able to see the duct slightly to the left. So this is the pulmonary artery. We are not able to exactly appreciate the branches, but this is the left pulmonary artery. Okay, this is the LPA, and the RPA is slightly invisible here. And this is the aorta, descending aorta. So here the PDA is closed. You can see a white wall between the pulmonary artery and the aorta. Usually in the presence of PDA, there is flow seen between the pulmonary artery as well as the aorta. So Dopplers you can measure for the descending aorta here in this view. And normally we'll expect an antegrade flow in the diastole. So since the baby is not copied, maybe we'll go to the next one. So this is the zippered view where we are able to see the IVC as well as the aorta. So this might be slightly disturbing to the baby because we are going to apply little pressure in the abdomen. So this is the IVC, it is almost collapsed. You will be able to make out the IVC because it is opening into the ventricle. So if you tilt the probe slightly to the left, you will be able to see the aorta. So we will try to demonstrate that in other baby. So this is the short axis parasternal view. Here the aorta is in the center. The left atrium and left ventricle and the right ventricle are all surrounding the ventricle. In this view, we will be able to see the ventricular septal defects, especially the membranous defects, and also we will be able to measure the ejection fraction. Coming to the apical view. So apical view is placed by placing the transducer in the apex area, usually closer to the nipple. So sometimes you may have to tilt the probe a little anteriorly. So we are able to see 4 chambers here. The ventricles, right and left ventricles, the right atrium and right ventricle, and the left atrium and left ventricle. So here the ventricular septum is intact. There is no flow seen between the ventricles, and you are able to see the red flow. The transfusion is seen above and there is red flow, which means that blood is flowing from the right atrium to the right ventricle. In case of there is presence of PPHN or tricuspid regurgitation jet, we will be able to see a blue jet here. So we can see the contractility in this view. We can also see the chamber dilatation in this view. And this is the left ventricle with cardiac injury, and this is the left atrium. Here the atrial septal defect is slightly present, which foramen OL is present. And if you kind of slightly tilt the probe anteriorly, you are able to see the aorta. The Mercedes-Benz sign is seen. So on tilting further, the aorta is opening into the left ventricle. This is the left ventricular outflow part. Okay, so the aorta is opening into the left ventricle. So we will try to demonstrate the PDA in another baby. Follow all aseptic precautions, clean the baby, clean your hands. So this baby, as you can see, is having mild respiratory distress. The baby is already on CPAP support. So here again, we first start with a flat view. Parasternal long axis view, where the probe is placed high parasternally with the probe mark towards the right shoulder. So here the central one is the aorta. So this one is the aorta. This is the left atrium. So even by eyeballing, you can see that the LA is dilated here. The aorta is opening into the left ventricle, and the upper chamber is the right ventricle. So in this view, you can measure the LA by AO ratio. Usually we place M mode across the aortic valve. So we can visibly see here the aorta is having a narrower diameter compared to the aorta. So we measure aorta at the end diastole, and we're going to measure the LA at end systole. So this is the end diastole. We need to be doing it at the level of aortic valve. So it is almost 0.49. Now coming to LA. So this is done at end systole. So this is almost 1.23. So the ratio might be coming around 2. And so like we just discussed, here we are able to see the aorta with aortic valve. The left atrium is dilated. The contractility seems to be okay. The left ventricle is also seems to be okay. The interventricular septum between the right ventricle and left ventricle is intact. So when we try to tilt the probe slightly anteriorly. Now the aorta has disappeared and pulmonary artery has come. So if you place color Doppler at this point and try to take the reading, so usually there will be only normal flow like this if there is no PD. But here you are able to see some flow in the diastole also from the duct. So that is because of the presence of PDA. In case you're not able to identify PDA from the ductal view, this is one view where you can place the Doppler and see the presence of PDA by the presence of diastolic flow. So coming to the ductal view, so we are able to see that there is some flow between the, there is some duct between the aorta and the pulmonary artery. Let's put color Doppler so that it will be more clear. So definitely we are able to see some blue and red jet here. But I'm searching for a more clear view. So this is actually the aorta, aortic arch and descending aorta. So this is always a good point to start with. When you try to tilt the probe a little left, you will be able to, the aorta will disappear and the pulmonary artery will come. Though the flow is not exactly clear because the baby is on CPAP support, we are able to see the red and blue jet here. We try to search for a more clearer view. So always measure the duct without the color flow. You need to measure at the pulmonary end of the entry. Do not measure the anterior wall of the duct. So not very sure if this is correct place where I have to measure, but since it's getting delayed, I'm trying to measure it here. So we'll always measure at the pulmonary end. So this duct is coming around 5 mm, I think 4.5 mm. So now you can try to place a Doppler here in the duct. Pulse wave Doppler needs to be placed. This is actually coming from the aorta because the aorta is also shortly connected there. So normally you see flow in the aorta both during the diastole also. This is antegrade flow in the aorta. So here there is absence of, there is no signs of HSPD in the iota at least. So here we are able to see the PDA flow. So there is bidirectional flow. The flow above the line is the left to right shunt, and the flow below the line is the right to left shunt. So this baby though has a large PDA, still there is bidirectional flow, which means there is a component of PPHN also. So now coming to the apical view, four-chamber view. So there is not much gross dilatation, but compared to the right side, the left side is definitely appearing a little bit dilated when compared to the right side. TR we are not able to appreciate in this view. There is mild blue jet across the right ventricle, but it is not very significant. And towards the left side, it is predominantly a orange color flow, which means there is no MR. So now coming to the Zifford view. So this is the right ventricle. The IVC is opening into the right ventricle. So if you slightly tilt it towards the left side, so this is the IVC. It is collapsing well. It is not very dilated. Now, after tilting a little, we are able to see a larger, wider structure. This is the abdominal aorta. So these are the two branches. This is the celiac trunk, which is arising, and this is the superior mesenteric branch. So you can measure the Doppler flows here to discuss if there is any systemic hypoperfusion. So I think we'll end the session now. Thank you everyone for joining.
If there are any questions, you can post in the chat session. So somebody has asked for the link for the academic sessions. We'll certainly share it with you. Thank you for posting your number. So if there are no other questions, thank you everyone for joining. And we will meet you next week with another session on neonatal cardiology. Thank you so much.